Here I am. Okay, I am sharing the screen. Can you see? Can you see the screen?
No, we cannot see the screen. Can you hear
Oh,
us؟
yes, I can hear.
ما انا مش شايفين. اقول له اوكي وخلاص.
Uh,
اقول له اوكي وخلاص ولا ايه؟ ما مش معانا هنا. قدمته خلاص. قدمته، احنا مستعجلين لسه في جلسة. ماريو.
yes.
Proceed Mario, please proceed.
Okay. Can you see the screen?
Yes, yes dear, we can see it.
Okay, okay, thank you. So the title, thank you for the invitation. Thank you very much. The title of my presentation is Widening the Scope of HIFU Indication in the Brain. Starting from the title, the brackets tend to signify that I will focus not on the high intensity ablative application of focused ultrasound, but rather on the emerging role of the low and medium intensity application. In particular, I would like to focus on its use in the treatment of glioblastoma. The therapeutic potential of focused ultrasound, as you can see in this scheme, has been understood since the 19th, but the lacking of real-time imaging to visualize and verify target or the location of lesions was indeed a great limit. It was only recently addressed when thermographic maps and anatomical maps were introduced. And since then, as you can see, research to expand the clinical application of focused ultrasound technology has increased greatly. So here there is an overview of current potential clinical application of MRI guided focused ultrasound. This is just a list, but in this scheme you can see that FUS is categorized as high intensity, medium, and low intensity. The high intensity uses the thermal effect for tissue ablation. And this ablation in a neuropsychiatrical disorder is a functional ablation, as it goes to interfere with the functional brain circuits, switches off part of these circuits. The medium intensity employs non-thermal effect, and it relies on mechanical perturbation and acoustic cavitation. And for example, it allows for brain-blood barrier opening that is currently used mainly for the glioblastoma, but also in degenerative diseases such amyotrophic lateral sclerosis and Alzheimer's disease. Other potential application relies on low intensity focused ultrasound with sonodynamic therapy that we are starting in these days in our institute, and also based on neuromodulation, on depression, epilepsy, and also on disorder of consciousness, in particular in traumatic brain injury. So here, I would like to focus on the glioblastoma. As you know, this tumor is the most aggressive and difficult to treat type of brain cancer. It has a very poor prognosis. The survival time for patients that undergoing the standard treatment with the surgical debulking and then chemotherapy and radiotherapy is very limited to few months. One key aspect that limits the efficacy of current treatment for glioblastoma is that the drug delivery is not sufficient in the tumor, in the tissue, in the pathological tissue of the tumor. Because the diffusion of chemotherapeutic agents is hampered by the presence of the brain-broad barrier. Glioblastoma, indeed, is characterized by a very heterogeneous integrity of the barrier. The core of the tumor, that is the part that enhanced in T1 post-contrast, has a dysfunctional barrier, largely due to the abnormal neoangiogenesis. But the surrounding tissue that is not enhancing on T1, but that is hyper intense on the long TR images, is the infiltrating part of the tumor. And this part, in this tissue, the barrier is intact. And that's why in this part of the tumor, the drug cannot be delivered and cannot diffuse properly. So the focused ultrasound help to address, I don't know if to solve, but to address this issue, because it induced a temporary and localized opening of the barrier by using the low-frequency ultrasound wave in combination with microbubbles that are systemically administered. Just a scheme, the exact physical mechanism underlying the effect of inducing the barrier opening upon excitation of the bubbles with ultrasound energy is not completely understood. Two mechanisms have been proposed: stable cavitation and inertial cavitation. Stable cavitation occurs when low pressure sonication is down. It stimulates a repetitive and regular pattern of microbubble oscillation. This motion causes the microstreaming of the fluid through the tight junction of the endothelium. On the other hand, the inertial cavitation occurs under high pressure sonication condition, and it results in collapse or disruption of the microbubbles that causes strong mechanical forces to disrupt the endothelium. The important point is that the barrier opening induced with focused ultrasound is reversible, is temporary, and is localized. Okay. In the next few slides, I'm going to show you some images that, from my point of view, are very relevant as a neuroradiologist. They come from a very recent participation of our institute, the Cairo Besta Institute, in two different multi-center studies aimed at establishing a feasibility and the safety of barrier disruption along the periphery of the tumor. This is an example of a patient. Here you can see the originary glioblastoma, the center of the lesion with the necrotic core, the peripheral enhancement, and in the flare you can see the hyperintensity of the edema that is both vasogenic edema, but also infiltration. Here you can see the postoperative images with the cavity, the surgical cavity, a very well done surgical intervention. And then after a few months, you can here look at the recurrency of the pathology. There is a pathological recurrent tissue around this side of the previous surgical cavity. And also this part was removed. Then this patient entered in our studies. This is the resonance setting. These are the microbubbles. This is the setting that you already know. This is the workflow in the barrier treatment. So the patient is prepared. We acquired the imaging on site for the planning. Microbubbles are injected. Then we start with the sonication. There is a control that is a thermometric, but the most important control in this case is the real-time acoustic control. And then we look sonication by sonication at the tissue star maps. And at the end of the treatment, we look at the T1 with the contrast by gadolinium. This is the lesion that we were looking at of the previous patient. And these are the area that we are going to sonicate. So as you can see, our target is the periphery of the surgical cavity, and is the surrounding pathological tissue all around the cavity. That part that is not actually enhancing, but that is pathological because it is infiltrating. These are the intraoperative images. You can see this dot spot, the white spot after enhancement, the subspot, because we proceed to sonicate with 64 subspot for each single region. This is an example of what we are monitoring during the treatment. This is a tissue star maps, and this is before the sonication, and this is after the sonication. Here you can recognize these black dots. We don't know exactly what they are. Maybe they are microbleeds, maybe they reflect the opening of the barrier. We don't know if this opening with these dots, these spots, is traumatic or not traumatic in essence. We don't know if the dosage and the power of sonication can increase or not the number and the presence of these dot spots. We, for the moment, know only that they are there after the sonication. This is the control after the treatment with the T1 post-contrast, pre and post-contrast with gadolinium. And here you can see that before the contrast, you have the tissue without enhancement. After gadolinium injection, you have this marbling perivenular pattern of enhancement that is typical of the blood-brain barrier opening. This is the radiological feature of the barrier opening. But we also perform the SWI imaging before, after contrast, and we can see together overlapping the black dots and this white hyperintensity that correspond to the enhancement with the gadolinium. So with this kind of images, we can recognize together the two radiological epiphenomena that are the correlate of the treatment. And here you can see the same patients treatment by treatment. So every time you can see that you have this enhancement perivenular in the surrounding tissue around the cavity. After 24 hours, you still have this enhancement, although it is less prominent because we know that the effect is reversible. When the patients come back after 1 month, you don't have anymore the enhancement, so to demonstrate that the effect is reversible. And then after another treatment, you have again this kind of enhancement in the surrounding pathological tissue, the peritumoral tissue. However, and that is not the case that I show you this image. However, this patient had a very poor prognosis and he died, unfortunately, because during the treatment, he developed a dissemination of the glioblastoma. And so we found this this part of the tumor that was specifically in the dura, it was a meningeal dissemination of the tumor. And here you can also recognize in the parietal lobe, in the intraparietal lobe, that is a multicentric localization of the glial lesion. Indeed, we retrospectively found that this nodular pathological dissemination of the disease was already present 1 month before, and we could monitor the pattern of augmentation of the tumor, of the increasement of the tumor. This is another patient of the which we treated. In this case, you have this surgical cavity in the anterior part of the temporal lobe, and after contrast, you have this enhancement linear all around the cavity. And these images lateral on your side are subtraction maps that show you the enhancement all around the cavity. That is the effect of sonication. And this is also very interesting. With the FLAIR images, we can demonstrate that in the sulci all around the cavity where we sonicated, we obtained this extravasation of fluid, of proteinaceous sovraliquoral fluid that you can recognize here with the subtraction maps. And also here you can recognize that in the middle of this intraparietal sulcus, before and after treatment, you can see a difference. After treatment, you have the white hyperintensity between the sulci. So it demonstrates that there was an extravasation and there was a local reactivity of the barrier. To conclude, this is a very nice series of images. Look at the cavity in the temporal pole. Posteriorly to the surgical cavity, you can recognize the edema and infiltrating tissue. And treatment by treatment, you can see that this hyperintensity disappear in after 5-6 cycles of treatment and chemotherapy. This hyperintensity is not anymore visible. These are just to summarize the parameters that we usually monitor during the treatment. The treatment is long, is time consuming, not the sonication time itself, but the table time. So all the stuff to prepare the treatment itself is annoying and is quite long. The literature, other groups says that the survival rate up to 1 year for their group was 100%. They conclude that this procedure of the opening of the barrier is safe, without complication, and has benefits, survival benefits. From our point of view, we agree for our experience that the treatment is safe and is feasible. For the efficacy, we have to prove it, because we have a example of like this, in which indeed the treatment seems to be effective, but we have also a dissemination of disease, like in this case, in which the patient completed only 3 cycles and then he dies during the treatment. So on this issue, we cannot be conclusive. We have to wait. We have to enroll more patients and to see it in the future. Thank you. This is the group. This is not a single subject work. These are all the members of our group. Thanks to them.
Thank you, Mario, very much for your exclusive presentation. Thank you very much. And thank you for coming live on such short notice. Thank you very much. And now, for the sake of time, we're going to conclude this session, and we're going to start the new session, the last session. And I would like to apologize for the delay for our dear chairman and speakers. And Dr. Safa is the moderator of the next session. يلا بينا.